guys, my name is Paige Walker. I am a paramedic for Catawba County EMS. I have been a paramedic with Catawba County EMS since May of 2016 and recently went part-time to pursue teaching endeavors. I'm really excited about this opportunity. I'm going to be teaching Allied Health Sciences and EMT to high school students. So today's class, we are going to be talking about blind insertion airway devices. So there are many different options of those that are approved by the state, but today's class is going to be a skills class on King Airway. So just a little bit of information. We're going to go through a PowerPoint first, so everybody will watch the PowerPoint, and then we're going to do the skill. So the PowerPoint will be short and quick, and then, like I said, we'll do the hands-on portion of the class. So just a little bit of information. A blind insertion airway device is a device used for airway management. It ensures an open pathway to the patient's airway to the outside world. It reduces the risk of aspiration, and it also is placed without direct visualization of the glottic opening, hence the word blind insertion. So some types of blind insertion airway devices that are approved by the North Carolina Office of EMS is a combi tube, LMAs, iGels, and King Airways. So some of those or all of those may be approved by your agency. Those are kind of agency specific. I know that combi tubes are, not necessarily the new modern thing. iGels are the newest thing of those. So whatever your county or your agency uses, but today we're going to be covering King Airways. Okay, and all of my information I got from the ncoems.org website. You can go on the website and you can go under procedures, and under procedures you can choose Airway Protocol 2, and that is going to be the procedure for a King Airway. And like I said, all of my information I pulled from the state website. So you can go on there. A King Airway is a skill that is for basics, advanced EMTs, as well as paramedics. King Airways are used a lot of times by our first responder agencies on things such as cardiac arrest before our ambulance service gets there. Depending on your agency-specific rules, sometimes I know there are some agencies where this is their first advanced airway method, and then endotracheal intubation is left to FTOs or supervisors, shift supervisors. So whatever it may be, it is an advanced airway. It is not direct visualization of the glottic opening, so we are not sure. Obviously there is going to be some air going into the stomach. But once again, it is an advanced airway, so it's great for if you have patients that are entrapped and you can't get to them to be able to visualize that glottic opening and those vocal cords. It's great to have an airway in place if you know there's going to be an extended time that they're in that position, or facial trauma. If there whatever reason that you can't do an endotracheal intubation, or if you're not allowed to because of your agency rules, like I said, this is a great advanced airway. So you can go on the website for NCOEMS and you can pull off those procedures and you can read through it yourself as well. I can send you guys all the PowerPoint, and that has the information on it as well. So let's talk about some clinical indications for a King Airway. When and why would we use a King Airway? So one of the biggest things is that, I know you guys think it's funny, but your patient must be unconscious to have a King Airway. So that's a big one that we need to make sure they are unconscious. Another one is inability to use a bag valve mask, to properly ventilate your patient with a bag valve mask. So for whatever reason, whether you're just not able to ventilate them with an appropriate saturation, or whether it's because of an injury or patient size. So So whatever it may be, there's a lot of factors there that can play into that. But that would be a thing if you're just not able to ventilate them with a bag valve mask. Another situation is if you have a longer transport time where you're going to need an advanced airway. That's a time when you would use a king. Another reason is if the appropriate intubation is impossible, like I said, due to patient access or difficulty of their airway. Say you have a patient that does not have a neck, and you know that they are going to be a difficult intubation, and you know that there are a lot of things that need to be done on this scene or to this patient for patient care, and you're not wanting to waste critical time trying to get an endotracheal intubation, that where you could just know that they have some type of advanced airway in place and you could do this skill and move on to something more critical. So that's another reason. One more clinical indication would be inability to secure an endotracheal tube in a patient who does not have a gag reflex, where at least one failed endotracheal intubation attempt has happened. So you've tried with that ET tube and you were not successful, and once again, you're not wanting to waste time, you're wanting to have an airway and move on because we've got a lot of things that need to be done for this patient. That's another reason. And once again, must be unconscious, don't forget. So we're going to go over some supplies that are needed for this skill. Some of them might sound very basic, but we want to go over everything that needs to be covered. So PPE, obviously we would need gloves, eye protection, mask, whatever's required for you by your agency, but those are very simple, should have PPE supplies. Another obvious is oxygen. You need to have oxygen to hook up for this patient. You need to have a bag valve mask, a stethoscope to auscultate once we have the king airway in place. You're going to need some lubrication. In this case, we have lubrication for the mannequin. We're going to need a 60 cc, like a lavage syringe. And most of your king airway packets, these come with these, but for whatever reason, it would always be good to have one extra on hand. And then this would be your king airway. We need an appropriate size for the patient, and we'll go over size indications in a minute. But appropriate, and these are how they come. They come with the king airway, the lubrication, and the lavage syringe. And then they also come with a little card that gives you information. It also gives you instructions. But on the scene of an advanced call is not the time that we need to be reading these instructions, but they are there as a reminder. And then we need this is a commercial securing device. If your agency doesn't carry them, tape, whatever you use to secure the airway in place. I have an OPA, NPA would be fine. And then we have capnography, so end-tidal CO2 detector. And then obviously, it's good to have suction in case you need suction. Have that handy, as well as a cardiac monitor we don't have present. And then you're going to need pulse oximetry. So cardiac monitor, this patient in this situation, if they're getting an advanced airway, they're obviously going to be on a cardiac monitor. And then we'll need that cardiac monitor to monitor the pulse oximetry and the end-tidal waveform. So we're going to run through the procedure really quick on the PowerPoint, and then we'll move forward to doing the skill. I know that some of us learn different, so we need to visualize it on the paper or the PowerPoint before we actually do the hands-on. So we won't spend a lot of time going through that, but I'm just going to read through the procedure that the state kind of documents on the website, and then we'll move forward to doing the procedure. I'm going to demonstrate the procedure, and then you guys with your mannequins, we are going to let you guys run through that as well. So pre-oxygenate your patient. That is a number one step. We need to make sure that this patient is oxygenated before we take that oxygen away and start trying to mess with the airway. Number 2, we need to select an appropriate size tube for the patient. So we're going to be doing adult only today, just for that sake. There are pediatric King Airways, but for today we're going to do adult. We're going to deal with size 3, 4, and 5. So we'll start with size 3. Size 3 is for anyone that is under 5 foot. So 4 to 5 foot. That's a size 3. So size 4 is the red. That is for anyone 5 to 6 foot. And then size 5, purple, that's for anyone over 6 foot. And so if you'll read on the side of the tubes, it'll show you the size, and then this great little tool right here, because sometimes you might not use these a lot, or for whatever reason you just forgot, you're in an emergency situation, you're excited. It has right here how much air needs to be put into these. So that's great. So for the sake of this mannequin today, we're going to use a size 3. And then you're going to need to grasp the patient's tongue, pull the jaw forward. What you're going to do is you'll insert the tube in the corner at a 45 to 90 degree angle laterally, and then once you insert to the base of the tongue, you're going to move that tube back to the midline. You're going to push the connector all the way down until that connector is at the lip or the teeth, okay? And then we're going to inflate that balloon to whatever appropriate size air. And then we're going to ventilate the patient. While we ventilate that patient, we're going to slowly pull back on that tube until we feel like that patient is easily ventilated. And then we're going to stop. We're going to hold that tube in place and secure it with a device or tape. And then we're going to listen for breath sounds, okay? So kind of doing all of this simultaneously. And then we're going to hook up our end tidal as well, okay? So I'm going to go through this shortly, and then we'll let you guys go through it. So we're going to start. You want to pre-oxygenate your patient, okay? You want to make sure you're getting good chest rise and fall, that EC for the hold of the mask, ventilating them good. So once we've reached an appropriate oxygen saturation that's safe, okay, at this time our OPA would also be in place. Grab that, okay. So we measure that. We can measure it from the corner of the mouth to the tip of the earlobe, the middle of the mouth to the angle of the jaw. So we'll have that in place while we're oxygenating the patient. So now there's a safe oxygen saturation. We're going to remove that. We've got our tube ready. For the sake of time, we've already lubricated it, okay? So we want all this handy to us. So I'm going to move all this stuff over here to me. And you want to make sure it's all organized and set out. So I'm going to take that tongue, hold that jaw, and I'm going to pull forward. I've got the number 3. I've got it lubricated up. I'm going to insert at the corner of the mouth at an angle. And once I get to the base of that tongue, I'm moving to the midline and I'm pushing down, okay? I've got it all the way to the lip. I'm going to get my syringe. Now for the number 3, it tells me that we need 45 to 60 mLs of air. So I'm going to pull back to 60 just for safe. And I'm going to push that in. I'm going to leave a little bit. But I'm going to push that in. And as I push it, you'll kind of notice that it seats itself. So that balloon seats itself. So I'm going to put about 45, 50 in there. And then I'm going to get my bag back. Go ahead and attach my end tidal. So that's hooked up to my monitor. I'm going to hook up my bag. talked about, slowly pull back until I've got easily ventilation for my patient, equal chest rise and fall, okay? So we've got that. So we also want to get this in place, okay? So since it's a one-person thing today, we want to get this in place before we lose it. So be sure that you are marking what point you have this at. So whether it's, the connector was right above or however, we want to know where the placement is so that just in case it moves, we want to know that, hey, we're not in the place that we were. We need to reassess here. We're going to go ahead and secure this device. Obviously, it would be ideal to have another hand here. We would have. So as we're bagging, we're wanting to check breath sounds for equal, okay? And then we're also wanting to listen to epigastric region. Now be aware, this is not an endotracheal tube like we discussed, so it is going to have some gastric sound. Might not have equal on both left and right for lung sounds, okay? So we're looking at our monitor, we're confirming that we're good, we're moving on to the next step, okay? So, any questions? No questions? Okay. You guys, I'm going to let you get your mannequins now. We're going to go through it yourself. I'm going to be walking around the room, see if you have any questions, looking at your technique, making sure everything's going good, okay? All right.